Welcome to Legacy Sips and Tips podcast with your geeky host, Lindsay Wheeler, where we talk about everything from death, preparing for your future through estate planning, life, the occasional breakup, entrepreneurship, general nerdery, and of course travel, snowboard, and always wine. Welcome to Legacy Sips and Tips with your host, Lindsay. And today we have Molly Wilder on. She is a nurse practitioner, or soon to be. Very soon to be. You've been nursing for how long?
14 years.
14 years. Molly has been nursing for 14 years, which is incredible that she still has a job after 14 years. But anywho, so this will be our episode. We're going to talk about life, death, nursing, what that looks like in estate planning, and yeah, here we go. Hi, Miss Molly.
Hi, how are you?
Hi, I'm good. Who's texting me? Nobody. Okay. ADD.
The only important person is right in front of you.
Correct. The only important person in my hair, like, man, I'm ADD is strong right now.
Yes, it
okay.
is.
So I've known you for a while. I play soccer with Molly and her sister and her brother. Tell me about you. Tell me about, you're from Nevada. Your dad was a firefighter. So you've grown up with craziness pretty much.
Dad used to investigate arson cases at times. And so he'd come home with pictures of all the things. He'd talk about cases that they'd go on and patients they'd deal with and whatnot. And so I actually didn't really want to get into nursing. I wanted to be a marine biologist. He told me to get a real job. So
as fathers do.
Here we are. Family kind of, as far as having conversations about life, death, all of the things have been very open. We don't really hide things from each other, and sometimes that's a good thing, sometimes it's not a great thing. But in the aspect of what I do and why I chose to do what I do, Dad definitely had a really big piece in that. You know, other family members are in healthcare as well, so it's just kind of the thing. My poor mother, bless her heart, as far as like having a regular conversation. She's not medical. Having a regular conversation at any dinner table is it's a little difficult for us. It always resorts to bodily functions of some kind.
Because you're the youngest of three.
Yes.
You have your darling sister, who I am very good friends with as well, and she is in the Guard. She is the Air Force Guard, so she deals in that kind of area, and she also did state intel, basically, for our state of Nevada. And then your brother's a firefighter.
Yes.
And then your sister-in-law is a nurse, ER nurse. So yeah, your guys' conversations are probably quite wild, and you never have holidays on the actual holidays.
Correct. Yeah, we always try and make it work together, but everybody's schedule is always, for example, Thanksgiving this upcoming week, we'll be doing it on Tuesday. I have to work Wednesday, Thursday. My brother works Friday, Saturday, and then I'm back to work at Sunday. So it's just like, when are we going to do it? We'll just do it whenever we can.
So what department in nursing, or guys, how did you start in nursing? What made you, obviously your family kind of trajectory that, as a side note, everybody, I wanted to be an astronomer, and my dad again said, get a real job because you really suck at math. Yeah. So here's why we're here doing this wonderful podcast just for you.
My dad's aunt actually worked for the Red Cross, American Red Cross, as a nurse, and she traveled and did a bunch of stuff, and so I found that quite heroic. Dad had always said, be a nurse, you have it in you to take care of people, which is so weird being the baby because I had no one to take care of. Whereas my sister, on the other hand, being the oldest, would be like, I took care of you guys all the time. So it's odd that Kit didn't go in, but the fact that, I did. I went and started working in an ER and I loved it. Like just something different every day, blood, guts, all of the things. I loved it. When I graduated, I immediately went into, it was hard to find a job. I went to school in California. Moving back to Nevada, if you weren't a Nevada or like UNR student, trying to get a job anywhere in town was really difficult. So the only place I could get a job was in a nursing home. So just talking about death and dying and that sort of piece, I kind of came crash course with that, where I had seen a couple people die like through school, but not necessarily, to
someone
that
you're
degree.
Taking care of.
To that degree. And so, working in a nursing home, you get most of them are elderly patients, a lot of them with dementia, chronic type issues. So the likelihood that they're going to pass while they're there with you is extremely high. So you just kind of got exposed to a lot of that in the early portion of my career. Then finally got a job. I was working out at Banner and Fallon. Ran my car off the road one day because I was working like ridiculous hours. We work 12 to 14 hours on a given day, plus the drive out to Fallon is an additional hour. I was exhausted. I fell asleep, drove off the road, had enough wherewithal to come around. And then my husband was just like, okay, you need to find something in town. So I found a job working on a med-surg unit at one of the local hospitals and loved it. Again, surgery, watching people come in, have the surgery, recuperate, and leave was pretty fulfilling. You get to see patients come in when they're really sick and then walk out. I kind of wanted to do more. I mean, my mom has always been like, kind of like pro-woman, like you've got the capacity to be a well-educated person. Why not go farther than that? So she kind of pushed for me to go back to school. That's why I'm doing kind of my nurse practitioner piece. And she told me to challenge myself. So the beautiful thing about nursing in general is that you can get one degree and there's a plethora of different jobs that you can do. Pediatrics, ICU, ER, hospice, home health, school nursing, like all of that is with your one bachelor's degree. And so I was able to then kind of transition from a med-surg unit. I was there for 8 years, I think. I was there for a really long time. Kind of climbed up the ranks, was doing supervising type stuff. Realized that that's not for me.
Molly is not a people manager at all.
I'm not a people pleaser. Being a Virgo, I was like,
fellow Virgos.
Yes,
we're the same personality.
So being a Virgo, I was like, I don't necessarily like doing this. So I was like, we'll figure something else out. So I transitioned into the ICU. So kind of coming back full circle to the death and dying that I saw in the nursing home, I'm now seeing in a critical care type situation where in the nursing home you kind of have an idea that patients are passing. You have time to watch patients pass. Often we have palliative care and hospice involved. In the ICU, people are dying and they're dying like right fucking now. You have to make decisions now. And that's both for us as medical staff as well as family members. And so kind of, I'm sure the whole point of me being here today to talk to you is about, having some sort of plan before you come into the hospital. And it blows my mind the number of people that don't. And so through your trust and stuff, that everything that you set up, I don't know to what degree as far as medical is concerned that you discuss with your clients, but it is extremely helpful when patients come in and they have an idea of, one, what their overall condition is, and two, how they plan to leave this world, because it may be their decision or not.
Right, and that's what I tell people. I'm like, this is literally the one guarantee you have in life. We are not going to make it. It is literally guaranteed to happen. So why would you not prepare for that? And we're fragile little meat pockets, as I say, you know what I mean? Like bad things happen to us very easily. And so I try to be very proactive with my clients about getting that set up, just because me personally, with my accident, as people might know on previous episodes, I had a really bad snowboarding accident. I almost died. I was in the ICU and laying in the ICU going, I got nothing in place. How embarrassing. And it could have, luckily I was able to verbalize what my wishes were or what I wanted to have done. But if I wasn't, who knows at that point? And so a lot of times too, people leave this too late, where they don't have the capacity to let people know what they want. They maybe have dementia, or they have Alzheimer's. So I really kind of hammer people, just because I have so many of you guys in the medical field as friends, knowing what you guys do and how important these things are. So I definitely have our powers of attorney for our medical decisions. We have a living will, which is your end of life decisions, and then you guys also have the pulse document that goes on the fridge, and we could talk about that for the first responders when they come. So tell me about that. Like, so as a medical professional, what are you guys looking for as guidance on our documentation that you guys like to have?
Yeah, I think the biggest piece, and again, the majority of the patients that I get are severely ill. And even something as simple as sepsis, say you have like a cut or you get cellulitis on your arm, it can systematically start to affect your brain, and you're like out of it. You're kind of delirious, you're not with it. And so your ability to make rational decisions on your healthcare kind of goes out the window. And so typically the next of kin, which is a spouse, or the firstborn child, if they have a relationship with that person, is typically who we go to. It gets kind of, there's like a huge gray area there in response to do you have an estranged relationship? Are you legally married to this person?
Right.
And that sort of thing. So our expectations is having somebody set up for that, a power of an attorney, or I think the other term is a surrogate that they use, where somebody who knows what your plans are, what your wishes are, and are able to communicate that to us and have it be
with paperwork.
Yes, legally set. We utilize our case management team quite a bit to kind of look into some of that. And a lot of people, it is surprising. It's one of the things every time we get a patient that comes in, we ask, do you have a power of attorney? Do you have a DNR? Do you have a living will? Do you have somebody else that can make decisions for you? And we'll get patients in their 80s that don't have that. Yeah. And you're just kind of like, the shit, man, like, how did you make it this far and not have anything else like set up? But it is something that, surprisingly, a lot of people don't. People who have children, I'm like, how do you not have stuff set up that if something were to happen to you, your kids are taken care of? It's kind of the same thing.
That's a huge one for us, is that guardianship nomination. I always tell people, if you have children, you should automatically have life insurance and you should have a trust, because we put in that guardianship nomination of what happens to you if you're in a car accident? What happens if you have a heart attack? What happens if just bad things happen? Where are your kids going to go? Like, that's a scary thing. And I think we talked about this in a previous episode as well, is that we had a client who was triggered to get her estate plan in place because her sister was unfortunately killed by a drunk driver. And she was walking with her young child, or two of her children actually. She had her toddler that she's walking with and her basically baby walking down the street during Christmas time to go get some hot chocolate with her kiddos, like wonderful little thing. Drunk driver unfortunately killed her. The kids were injured, but they had two different fathers. Those children were now ripped apart from their siblings. So not only did they lose their mom, now they don't have each other, which obviously they want to be with their siblings, because she had nothing in place. And that's what got her family to get her sister to get hers in place, because bad things happen. And I hate to say that, but people just think, la la la, we're in fantasy land, but really bad shit happens all the time, and you should be prepared for that. And that's why it's important for you guys as medical professionals, myself included. Like I said, I neglected it. I didn't think I was going to crash that day on my snowboard and almost die. Nobody thinks that, of course. I'm out there having a nice day with my friend's daughter, and here we are. I'm sitting in the ICU going, this sucks, So for you guys, having that in place is super integral. And so how do you guys facilitate that when people come in and you're like, hello?
If they don't have it, our case management comes and talks to them about exactly what that is. I believe we have a notary at the hospital I work at, or we can kind of contract one out, and they'll come to the bedside and they'll talk to you about stuff, and you can fill paperwork out right then and there and go forward. A lot of times, the severity of the patient's condition really kind of comes into play. Is this something that we have to address right now? Is this something that I'm going to treat this patient, they're going to go home, have time to go home, either whether or not it's on hospice or palliative care, and then they can have that conversation afterwards. But it's huge for us to really dictate how aggressive our care is going to be, right? So again, if we have somebody that comes in and again, their condition is something our doctors and our staff know that we can fix. It's just going to take some time, and the patient's ability to kind of bounce back from the illness is good, then, it's not something that we super push for. But we can,
and as long as they're communicating with you as well.
If they're awakened with it. And so then, but it's always interesting when they're not, and you're starting to talk to people, and then it just turns into a Jerry Springer fucking episode of like, this person who's been estranged for years all of a sudden wants to have a say, or this person over here who's their like second ex-wife, wants to have a say. And you're just like, okay, I need to know who is the closest person legally to this person that can speak for them. Then you run the risks of, is the person that is, whether it's their power of attorney or their surrogate or their spouse or whoever, are they making the decision for the patient, or are they making the decision for them? And that's the hard part. And so we have to have that conversation about, again, what would Lindsay want? What would Lindsay want in this situation?
Smother me with a pillow.
I know exactly what you want.
Correct. Smother me with a pillow.
And I'm happy to do it for you. But again, making sure that you're openly communicating about what the prognosis of the patient living through their situation, and what does treatment look like. A lot of patients and their families have no idea again, no one sits unless you watch Grey's Anatomy, which is bullshit, by the way. Unless you watch shows like that where you kind of get an understanding of what it looks like and what procedures, like you come in, you have appendicitis, you're going to have surgery, that sort of thing. They don't understand to the degree of what the patient has to go through in order to get better. Yeah. And sometimes putting the patient through all that extra shit is also more harm. It's going to do more harm than it's going to do good. And so, for example, I just had a patient a couple weeks ago, came in and he had necrotic bowel. He was, otherwise a healthy human being. The only other health history he had was like high blood pressure, hypertension. But he had over 100 centimeters of necrotic small bowel that he had to go in and get removed.
Eat healthy, people.
Right? Well, they say eat healthy, don't drink. You're still going to die at the end of the day. But,
right. Correct.
Anyway. But otherwise healthy gentleman went in, had this big surgery, had no idea, had no other related issues to that. Sometimes shit just happens to patients. They went in and they took kind of where they cut out the bad bowel and they put it back together. It's called an anastomosis. Well, it leaked. So you've just got kind of like
poo, just
bile
there,
and a bunch of other stuff leaking into this person's abdominal cavity. So he's getting septic. His body's going through septic shock, and he's starting to decline. And the surgeons sat and talked with, we have hospitalists, we have intensivists, we have all these other doctors involved in the case, and all of them were like, the prognosis is very poor. So what do we do? It's kind of damned if you do, damned if you don't. The surgeon said, he's like, if I don't take him to surgery, he's going to die. If I do take him to surgery, he's going to die. Now, don't get me wrong. My moral compass never points north. And it's a bad day if I'm talking about ethics.
Right.
I'm a fan of population control, so, I'm probably not the best person.
Cull the herd, everyone.
Yes,
just kidding.
Yeah, I'm probably not the best person. But in this case, at that moment, it was kind of like really the only options are to let this guy go as comfortably as possible. He's going to die either way you look at it. So how do we go about this? He had gone into surgery set as a DNR, do not resuscitate, and a do not intubate. But in order to do the surgery, they had to intubate him. So he's actively intubated on a very minimal amount of medications that what people would think is like an induced coma, right? Like we're giving him medicine to keep him sedated, but he's really not responding. And a lot of that has to do with metabolites and how sick and septic shock and all the things. And so the likelihood that he would have made it out from surgery as it was just on the physical aspect, we could have given him maybe another 2 or 3 weeks worth of life. But where does quality of life come into that play, right? So again, you have to take him back through surgery. You have to cut some more stuff out. You're going to, deal with pain. Was
this like a surgeon issue?
Things.
Like they messed up? Or
so
was just...
I think it was just the tissue was not viable, is what the surgeons were saying.
Rotting,
and the hard part with those types of surgeries, you don't know until you get in there. Yeah. So it's kind of like a car. Kind of like a crapshoot, right?
Yeah.
So he's like, the surgeon was saying, I could take him in. And he's like, but the likelihood that he's not going to make it out is pretty substantial.
Yeah.
So it's like, do you even aggressively treat that, or do you just say this is not good either way you look at it? And now we're having that conversation of comfort care, which allows us as nursing staff to provide medications until patients basically stop breathing, with family at bedside and all the other things. So he was listed as a DNR prior, and the wife and daughter came to the bedside and said this is not what he would want.
Right.
So we ended up extubating him, taking him off all the medications, and he died within 15 minutes.
Crazy.
Yeah, insane. Yeah. It's one of those, it's like, and families look to us. Now nurses, we aren't, really allowed to diagnose. We're not allowed to say, oh, you've got X number of days or hours, whatever, left to live. It's like, for the most part, we kind of, for those of us that have worked in it long enough, we kind of know.
But and the doctor will communicate that to them.
Docs have to come in and have that conversation. And the physician that was on that day did a beautiful job of explaining all of the things. And so the wife just was like, okay, like, I don't want him to suffer. Do what you need to do to keep him comfortable.
And this is probably a conversation, hopefully, him and his wife and his children, or older children, had at this point of like, unfortunately, the holidays time are coming. This is time to talk about this. Yeah. What happens? Or you can tell the story to them. Be like, hey, I heard this crazy story on this weird podcast about, what happens. What would you do in that situation? Or what would you want in that situation? So these stories kind of help you kind of breach that conversation because it's uncomfortable to talk about.
And like I said, he came in with a DNR already established. So it had been, his wife was set as his power of attorney. His daughter understood what that looked like, that if he starts to decline, and that includes no chest compressions, no intubation, no artificial feeding of any kind, that sort of thing. And there are, similar to this form here, that specify exactly what you want. So some people, if you don't have a cardiac condition, where it's like, if we give you CPR, it's not going to be a super big issue, or frail people, and I can't tell you enough, that initial pump on the first compression, when you crack an 80-year-old woman who has osteoporosis, when you crack that chest, that sternum, and then you continue with those bones just hitting the pleural cavity and all of the things, you run the risk of causing more harm than good. Sure. So really, is chest compressions a reasonable choice for you at this stage? So we sit down, and every patient's different, and therefore every plan is going to be different. Right. Whatever patients are in for, as far as their chronic conditions, their acute conditions, and how they're presenting. But then again, you have family. So family is the second piece that makes it difficult. When we have patients that don't have any of this set up, holy shit.
Yeah, I always tell people, I'm like, man, because you might want this, and I have, even when they're like, I want to include the family on these decisions that we're doing, and they're like, okay, I don't want any of these things happening, and the family members are like, oh no, we will do everything. Mm-hmm. We will make you a cyborg. We will call Elon Musk, and we will make you the first cyborg in the world, and you're just like, no, but that's really not what I want. And they're like, nope, it's going to happen. And you're like, well, when are you going to honor my wishes or what that person wants? And so, that's always the struggle. And that's why I think the power of attorney are so powerful in that sense, hence the name and the word power. Of attorney. It's so powerful. Of giving the medical professionals your wishes, not your family's wishes.
Yes.
So, super important.
Yeah. And so, obviously, any form of documentation, we request that if they have it. If they don't have it, our case management team can sit down with patients and their families and help them fill it out and file for it. And then it gets notarized, and then it's a legal document. So we go off of what those wishes are, and our doctors are very good about doing that. I mean, and again, a lot of people don't think about the cost of things.
Well, that's the thing, is that the default is you guys are going to do everything under the sun to keep that person going, because that's your default, because you do no harm, but two, also that's the insurance and the litigation that if you didn't do that and a family member decides to sue you because of that, that's the society we live in. So the hospital are going to automatically do everything under the sun regardless of whether you want that, and that's why it's important to give the instructions for that, because I hate that we even think we have to think about this, but the cost, and I have a lot of clients who are like, well, just pull the plug, even though if I'm semi-okay, because I don't want the inheritance going to paying medical bills. And I'm like, well, I'm sure your family would want you here instead of the money, but I understand the thought process, you know?
Yeah, and it's probably the most unselfish thing that somebody can do, and I hate to say that because, we do a bunch of stuff, and all of that stuff, you're going to get billed for it whether you live or you don't. Yeah. Somebody has to pay that, right? Insurance companies, to a degree, will cover some of those things. But again, they're going to say, well, you had a chronic condition. It was just a matter of time. You had this big exacerbation, and that's the end of you.
Like when you're doing surgery on a 92-year-old, you're like,
Putting a pacer in a 91-year-old the other day. I'm like, what are we doing? Yeah. Lived. God knows for how much longer, but
Well, I mean, sometimes it's important. Maybe they'll live to 110. I don't, maybe they get a lot more years, but the likelihood of that is probably pretty remote, but
it's educating people, and unfortunately society doesn't know, even with internet and everything that we're exposed to, this podcast, great. You're putting the information out there for people to be better educated on what to expect. Yeah. And so, we need to kind of work that piece out a little bit more, but a lot of that comes into cost. Now that I'm kind of making the transition into a nurse practitioner, I'm moving from acute critical care to primary care. Mm-hmm. Huge. You can't get any farther on the spectrum, but I do like to tell the patients that I'm working with in clinic that I'm like, whatever you choose to not do on the preventative side of things, I'll see you at my other job in the critical, in the crisis mode when shit hits the fan because you haven't been taking your blood pressure medication that I prescribed to you. Right. You know what I mean? And so just education on all fronts, but sometimes people just want that quick fix, and unfortunately it's not something that's always the case. So I think having a plan, educating your clients on what's available to them, and then when they come to me, them having it all set up and having a plan is great. I'll tell you a quick story about a patient who didn't have any of this stuff set up. It was, kind of a shit show. So, unfortunately, patient in his 60s or so, but very heavy into illicit drug use, but had like 4 kids, 4 different baby mamas, been married multiple times over, mother's still alive.
Drugs are bad, kids.
Right? Don't do drugs, okay? Mother's still alive, and the woman that he's currently living with, he is not married to. Okay. So trying to figure out who is going to make decisions for this man, as now he is in pretty good septic shock. His kidneys are failing. He's getting dialysis, pretty much non-responsive. His ammonia levels, which affect the brain, just making him completely not with it. So he can't speak for himself. He's not legally married to the woman that's living with him. His children want nothing to do with him because he's not been an okay father. And mom has been told by the lady that is living with him that she is not to make decisions. Right? So who do you go to? So it's hard for us, and again, time is of the essence, to try and figure out who's going to speak for this man. So what the hospitals can do is that you can have 2 physicians get together, and the docs
like
can
Voltron.
sign off. Yes, right. Exactly. Like, that's great. And so they can get together, they can discuss kind of what the plan is. And if we don't have somebody that's capable of making decisions, or say you have somebody who has 0 family and has none of this set up, the docs can ultimately, like, again, we will do everything that we can, kind of once we've exacerbated all of our resources to try and help patients. Then it comes down to 2 doctors sitting together and having an ethics conversation about quantity versus quality. What's the likelihood that this patient's going to come out of it? And then they have the power within their licensure to make a patient a DNR or full code and go that route, right? If they've said that there's absolutely nothing else that we can do, somebody has to make the decision, and you have 2 physicians with their expertise making that call. I've only had that happen since I've been in the ICU for the last 4 years. I've only had that happen probably like 3 times. It's very rare that you have a patient that has no family, or you have no one that wants to step up to make decisions for somebody. It's a rarity, but it does happen. And so, ultimately, yes, the decisions have been made for patients to go DNR, and then.
Well, that's what we talk about. That like it's super important. Like people who are single, who are not married, maybe don't want to get married, maybe don't like the government trappings, and having that authority for that person. You might be with that person for 40 years. That might be your person, your partner. But if you're not legally married to them, the way that our society is set up, that you have no right to make decisions for that person. Yeah. And that was a big deal with our same-sex marriages or not marriages at that point. That could be your person literally for 45 years. And at that point, if you don't have anything in place, they're going to be like, you can't be in here. You just have no legal standing, even though you should have been. That's your person for 45 years, but sorry.
Yeah, and you know them better than anyone else.
Right.
Yeah.
And then you might have maybe a parent who wasn't a supportive parent coming in and being like making these decisions all of a sudden for this person, and you're just out in the waiting room have no control. Or maybe you just are a single and ready to mingle person, and you don't want to have those, you just don't want that, or you don't have family members, you don't have supportive family members, or you're estranged from those people. Having these documentations in place are so important. Like for me, like I'm not married, I don't have kids. Like I would want you guys to make those decisions for me. I want my friends to make those decisions because they know me best. They are my family. My dad's overseas. He's not able to get here that quickly. My mother is on the complete other side of the country. Not having that accessibility when somebody needs to make those decisions right away is super important to have those advocates being able to come in and do that for you.
Exactly. Oh. Yeah. And it's hard. Again, you have patients that they're like, oh, call my brother who's, in England somewhere. And I'm like, that person can't get here.
Right.
I have somebody right here, but they're not legally established to make decisions for you. So they have to sit here and watch you die, basically. Yeah. So it is stressful. I will say death can be beautiful when you have a plan, when you're ready for it, when you talk about it, when it's, when it's your time. It can be a beautiful, beautiful thing. And we want nothing but patients to be surrounded by families. I actually had a physician once, you'll get a crack out of this, had a patient who he was telling the doctor that he's like, I think I'm ready to go. So he was lucid all the way up until, we started to give him meds, but he just wasn't going to get any better. So he said, just kind of take me out now. Yeah. So, and the physician said, well, you're okay. We'll keep you alive. We'll keep all these, meds and everything going for you as long as we can. Get some family in here. And he looks at me, he goes, you don't want this bitch's face to be the last thing you see before you die. And I'm just sitting there like, fuck you, dude. Like, I was like, I put makeup on today.
Yeah.
You know?
I look so pretty. I did my hair. I washed my hair.
I was like, I thought I was looking all right. But anyways, but the point is that like we try and push for patients to have a happy and peaceful passing as much as we can tolerate. COVID fucked everybody up on the aspect of like just what that looks like when patients code.
Oh, it was brutal.
You can't, we couldn't have patient family
iPad
members
in front of somebody.
Yeah,
and, it was
and they're
awful.
watching us, beat on people's chests and blood everywhere and all of the things. It was pretty traumatizing, but now that we're past that, we can kind of make things a little bit easier. So we do try to accommodate for stuff like that. But having somebody come in with a full-on list of exactly what they want, and everyone in the room present knows that that's the plan. Yeah. You can't ask for a better way to go. And so it makes it easier for us. Like, we have a plan between nursing staff and the physicians, which sometimes doesn't always, meet. Like I said, when I'm starting to have ethics conversations with doctors, that's a bad day. And so it just makes it so much easier, and the paperwork and everything, the stress of all of the things, and the acceptance of a patient's condition is just so much easier to deal with.
Well, and that's what I tell people. I'm like, this is for your family to make these decisions. You're actually taking that burden off of them. You've done the heavy lifting for them. That the medical professionals now know exactly what you want. Your family's not questioning, being like, oh, I don't know, what do they want? I want them here, but I don't know. That kind of decision paralysis that you are now alleviating from people. Mm-hmm. They don't have to be responsible or carry that burden or be like, did I do the right thing? Or did I not do the right? Should I have let them go? Should I have not have? I have clients who come to me because they're getting their stuff done because they had to experience that, and it was so traumatizing for them to do that. So you are actually giving the medical professionals the ability to make those decisions, and not your family and not your loved ones. And that is such a nice gift that you already had the plan done for them. Like, take that burden away from them. That's a horrible guilt to have for the rest of your days of whether you should have basically killed your mother or not. Yes. That's awful.
And a lot of people live with that grief, and they're like, I don't want to be the one to make that decision. I'm like, you don't have to when you have a plan. Right. She made that decision. She's going out the way she wants to go, and all you had to do was just agree with it.
Yeah, and just be here for her.
Yeah. When my husband and I just signed all of our stuff with a lawyer, I thought I made it pretty easy for him. He, on the other hand, bless his little heart, was like, well, what if you have this circumstance, then maybe I want to be on a ventilator for like 2 to 3 weeks, 2 to 3 months, and then if I'm not getting anybody any better, pull it. Can you imagine the bill that if he was not able to do that? And again, I know a lot of people aren't thinking about that, which unfortunately, with insurance companies, the way they're going to go, Social Security, how that's going to go, and Medicare, it's going to be a thing that people should start thinking about is, what is this going to cost me? I just had a conversation, I don't know if you're familiar with the Neptune Society.
Oh, yeah. If you ever sign up for them, they're great. However, if you just want information, they will hound you like the mafia that you owe money to. Great organization, however. But yes, the Neptune Society, love them.
Yes, but somebody to talk to about what happens after you die and who pays for what and all the things. But anyway, I was just thinking I could have killed him across the table as we're signing all of our paperwork, and he's like his was just like, well, if this, then this, if this, then this, if this, then this, and I just said DNR on all of it.
Yeah.
I was like, I don't want you to have to make that decision, because I know he would struggle.
For sure. Of course he would. That's, you're his wife. Of course he's going to struggle with that.
Well, and it's like, and then I have my sister, who, understands, I think, where I'm at with that. But after my car accident, watching the two of them, one wanted one thing, one wanted the other. One has a much stronger personality than the other, overriding that. And I'm just sitting in the bed crying, basically. Like, I'm like, I don't want this. You see families start to kind of come at each other at times, and it's like, if you don't want that, make a plan.
Yeah.
And all they have to do is, and they'll be told by us, by staff, that again, you can think and want whatever, like shit in one hand, want in the other. Right. This is what this person wanted, and that's we're gonna honor their wishes. Yes. Yeah. Legally, we are going to do that for them. Sometimes it doesn't always seem right. I mean, again, I'm listed as a DNR at the ripe old age of 38. Shit, 39. I'm old. I stopped counting after 35. But anyways.
Prepare yourself for 40, friend.
It's coming. But, to have the understanding that I do about how all of this works, both as, one, sitting down and talking with a lawyer, two, being on the medical side of life, I just want things to be easy. It's bad enough watching somebody die in a hospital bed than to then have to worry about again, did I make the right decision for them? Did I kill this person? No, you didn't. They had their own choices.
Yeah, it's a crazy amount of guilt. I have clients who come to me because they want to get their stuff because they don't want to do it to their kids, what their family has done to them. And it's awful. Like, it's awful. Like, me having to coach somebody through, being like, it's okay. You did the right decision. You know, this is what I'm sure the universe wanted, or God, whoever you believe in, wanted. This was their plan. You know what I mean? Like, it's awful to be like, no, you didn't kill your family. You know what I mean? Yeah. Like, it's a horrible feeling and a horrible guilt that these people carry now because you didn't get your shit together.
Yeah.
Like, don't do that to your people. Just don't do that to your people. It's awful. If anything, just get your powers of attorney in place. You know, do your estate plan later, do your trust later, but just get those powers of attorney in place. Even for kids, like, you have your kids going to college, they're 18. You're not able to advocate for them technically, you know. So having that in place for them, they go off to college, they party too hard at the frat party, they fall off the roof. Whoops, we're in a coma now. What's happening? So that's important and what they want. And, you know, having parents fight over whether their child wanted to be buried or wanted to be cremated, you know, that's awful.
Yeah.
You know, so these things we have to think about. So for you, so I know you used to volunteer in your role to prepare the bodies to get them shipped over to the ME. Like, give us the process of, like, so somebody comes in, maybe they're elderly, maybe they have a condition, and now they're ready to pass. What does that process look like? So now they have, you know, hopefully we have the family in there, we have our plan in place, and then they have now passed. What does that look like? Or what's that process of dying look like?
Yeah, specifically to where I work, we don't have a morgue. So that piece is a little interesting, and I was just discussing, we have some new staff that are working for us, so kind of walking them through what that piece looks like, what forms to fill out, all of those things. So
dying is a lot of paperwork, by the way, everyone.
It is. Don't do it.
Don't do it. Don't die. It's too much paperwork.
Do it after I've left my shift.
Right.
So we do, when we have patients that come in and the likelihood that they're going to make it out is not super great and they're on a ventilator, we contact donor. So, and donor kind of gets involved and they kind of look in to see whether or not this patient would be someone that can potentially save one other life, right?
The hyenas.
Yeah, yes, they kind of are.
No.
But they're respectful in a degree, in a degree that they kind of wait to talk to families. They give them an ample amount of time to kind of grieve and kind of process how patients are doing before they kind of stick their claws in. And there's a lot of work that goes into patients that are donor candidates. That's a whole other podcast. But anyway, we talk to donor, and when patients die, when we do time of death, they're the first people we call, because with donor, time matters on what tissues are viable after death. And there's not a whole lot, things like skin, eyes, hair, teeth, things like that, things that you wouldn't think we're getting super morbid into that. But, but you'd be surprised at the amount of people that can, you know, take those organs. And so once they've been listed as not an organ donor, then we call the coroner. Mm-hmm. So
that's a medical examiner.
Yes.
Yeah.
Yes. And so with that, it really depends on their age, their cause of death, any other like complications. Like you asked earlier about the surgeon, was it a surgeon complication? Sometimes they'll look into that to see, was it just, in that case, did the surgeon fuck up? Or was it just really that the patient's condition was well beyond what the surgeon could fix? And so we sit and we talk with the medical examiners for quite some time, and we give them all of the tea on the patients to all of the degrees, and then they determine whether or not that patient needs to be a coroner's case.
So that's when they would do an autopsy and an investigation.
So then they would come and retrieve the body, take it back to the coroner's county coroner's office, and do an autopsy and kind of go with that. And then they take over, like reaching out to family, talking to family, because that's got to be kind of scary too. Like you have a patient that dies, and then they're like, oh, by the way, like we're going to do an autopsy because we don't know, was this malpractice? Was this something else that was going on? We've had a couple poisonings and things like that. We have patients that were like, it looked like it could have been an attempted suicide or something along those lines.
How much life insurance was involved?
Yeah. Come to find that a patient was chock full of antifreeze.
Oh my gosh.
Yeah. So stuff like that.
Did they owe money?
Like,
just kidding.
I have no idea. You know,
was it a mobster? Was it a estranged wife? Like, what was it?
Yeah,
these are
like,
fun.
Who's doing this? And I'm like, this is going to end up on Forensics Files, and I'm going to watch it. It's going to be great. But so once they're cleared from whether or not they need to be a coroner's case or not, then they get released to basically the family. Families can decide where, you know, which mortuary or funeral home, based again off of your plan. If it's listed that they want to be cremated, and maybe you even already have that funeral home set up, like,
That's where we have in our estate plan, we have our burial cremation instructions. You get that pre-set up. We've talked about the cost of that, like with the local mortuary and things like that.
Yeah. The hard part for us
pre-purchase your plan today and lock in that rate.
The hard part for us is that, again, because we don't have a morgue, we kind of need to move that body like now.
Right.
And so here you have a patient who just passed, their family's still at the bedside, they're grieving, and I'm like, here's a list of our local mortuaries. Please pick one.
Please.
Like now.
Please. Yeah.
And then having to describe that, which can be slightly morbid for some people, because they're like, we're still trying to process the fact that my father just died.
Right.
And now you're telling me that I have to already figure out where he's going to be buried, and especially in those cases where maybe the patients didn't have these chronic diseases where they were like on the brink of death to begin with, or it wasn't expected. Something like if they had cancer is one thing, if they didn't. And they're just like, I'm still trying to process this, and now you want me to figure out where to have him buried? Like, is that nuts?
Shoving paper
and
in
I'm like,
front of my face,
I'm like, well, yes, because they can't stay here,
Right.
And so
you don't have to go home, but you can't stay here.
Exactly. Yeah. And so often we will say, and the beautiful thing about mortuaries in this area is that they communicate with each other. So you can send a body to one place, and if you decide that's not where you want to do any services through, they will for free send the patient wherever.
Yeah, our death community here is actually really cool, luckily. Yeah, I think we have a good system here.
Yeah.
Good people who run these.
They're pretty quick at coming to pick them up, that sort of thing. And they're very
That's once
respectful.
the ME has released them, though.
Yes.
Because now they're at the ME's office being processed or being held, and then
from there, yes, once they've decided that this isn't foul play, that nothing else really needs to happen, and then they just say it was a death.
And that could be within hours, right?
Oh, yeah.
Okay.
Yeah. Yep. And again, that's why when we call the medical examiners, they kind of, I don't want to say they hound us. I mean, they need the information, as much information as we can give them for them to determine whether or not they feel like this particular case, like there's something a little off and they need to investigate a little bit further.
Right.
But often, and again, in the 4 years that I've been working in the ICU and the 14 years I've been working as a nurse total, I've only had one coroner's case, and it was like a 28-year-old, again, that they thought was an accidental overdose, only to find that he had been poisoned. And so that piece went. And unfortunately, we don't really, unless you read the paper or try and follow up on it, you don't hear, they don't call you back and say, hey,
Yeah, by the way.
Yeah, I'm like, I'm eating the popcorn, I want to know, but at the same time, it's, I'm not privy to that information. Yeah. So, but anyways, I've only had maybe one, maybe two cases that have ever been coroner's cases. So once the families have chosen a mortuary or funeral home for this patient to go to, then we do what we call post-mortem care. And it sounds morbid, but I love this part. And a lot of it, again, in the ICU, patients have lines everywhere, right? They've got, if there's an orifice, it has a hole in it.
Right.
And if there's not an orifice, we'll make one. So, they have lines, they have drains, they have IVs, they have tubes, all the things. So we take all of that out. Oftentimes, if it is a coroner's case, they want you to keep all of that in there because sometimes their cause of death may be caused by something we did.
Yeah, malpractice
or
something.
So they say don't take any of that stuff out. It also helps the mortuary sometimes, especially if they have a central line, for them to inject the formaldehyde to actually preserve and do all the things they need for the body. So sometimes
that's only if you want embalming, though.
Yeah.
Okay.
Yes. Yeah. I don't think if you go down the route of cremation, obviously, I don't really care about that stuff. But so we go in and we cleanse the body, basically do a mini bed bath, take all the lines out, dress them, all of the things, and try and make that person leave us with dignity. Yeah. And you can get into all the superstitions about things. Our hospital windows don't open,
which is very disturbing to me.
It's like they're on me.
And that's also every time I go to the hospital to do work, somebody usually codes in front of me, and I feel like I have to be a shepherd to help them out because their windows don't open.
Yeah, well, you are a walking black cloud. So.
Fair. I will shepherd. Bring me some change, and I will help you across the river.
And sometimes the angel of mercy is a beautiful thing.
Yeah.
Sometimes you need it in your life.
Every single time I go to the hospital, somebody codes in front of me.
Oh, don't bring
every single time.
Maybe you should bring me lunch.
I mean, yeah. I'd make your case a little bit lighter. Just kidding, everyone.
And so... Yes, we cleanse the patient, we get them prepped, and then the mortuary comes and puts them in the body bag and takes them out to wherever.
But now they're clean, they look presentable, the family members can be there.
Yeah, and it usually takes like 15 to 20 minutes if the family's still there. And I've had family members, depending on different religions, want to assist in that piece.
Yeah, that's cool.
I believe it's pretty big in a lot of like Indian, like Hindu, and some kind of Asian countries that they want to be, it's like what they do. It's kind of like a village type, helping out type of deal. So some family members will ask to be present. Some obviously don't want to do that. And then, but yeah, it takes about 15 minutes. And then we give patients and their families as much time as they need to kind of spend those last moments. And then on the other end of it, while they're doing that, we're dealing with all the paperwork. Yes.
Yeah.
So one thing that we always check before when we start to see patients start to decline is, do they have a DNR and do they have their PULSed? Yeah. If they have a
What does PULSed stand for?
So PULSed stands for Provider Order of Life-Sustaining Treatment. And when you have a patient that decides that they want to be a DNR or have certain things done or not done, once they kind of get to end-of-life care, they sit and they talk with the docs, and this piece, this little form here, it's typically
bright
pink. Yes, and we typically we'll put them above the head of the bed. So at the moment, if you're like, shit, we need to code this patient, somebody starts CPR, you see this bright pink form and we just check it. And it does give you options on, do you want CPR? Do you want me to crack your chest open? Because I'm gonna drop a bow. I was like, but then you can say things like, I want full treatment at all times, or I want selective treatment. And it's goal-based on your condition and what you want. Again, religious pieces come into play with this, cultural things. You can do just comfort measures that say, like, if you start to decline, just let me go, but keep me comfortable, don't do anything. And then you
Give me all the morphine in the world.
Yes. And then you can do things like, do you want to be tube fed? Like if stroke patients, a lot of times.
Artificial nutrition or hydration. That's also included in the power of attorney as well.
Yes,
Kind of what those circumstances or situations look like.
And certain forms of that can be very expensive. And to the degree
and kind of physically traumatizing too, right?
Oh yeah. I mean, we see patients, their muscles get atrophied, and they, as far as certain things that are in a lot of those medications can cause diarrhea, can cause all these other things. So it's like, again, you're getting fed, but you have all these other issues going on along with it. The
side effects outweigh the benefits a lot of times. Yeah.
But you can say, I don't want chest compressions, but you can intubate me if my lungs, if breathing becomes the issue. Or I don't want any of those, I just want some what we call TPN, which is what is given through the IV that has nutrients and things like that. Or I want tube feeds, which again, it can be not great trying to put an NG tube in through someone's nose that goes directly into their stomach, and then we just feed you through a pump. Some people, and it's not necessarily all the time. If you needed that all the time, then you'd get a PEG tube, and that's a surgical, pretty quick surgical incision. But then you totally forego the process of swallowing. Like I said, stroke patients are some of the big patients that have to deal with that. And again, think of quality of life. It's going to definitely give you quantity of life, but to what degree and quality do you want to be stuck to this machine?
38 states have a general form, if you will, for power of attorney, which is great, so that it's consistent across the board, so we all can follow it, which is really nice. And Nevada has just updated theirs to be on board with that, which is also really nice. And a lot of those questions are now more informative of like, how important are these things for you? How important is it for you to stay alive if you have substantial physical limitations? How important if you have substantial mental limitations? Not normally like I do, but above and beyond.
We can't fix those.
How important is it for them to talk to your family? How important is it to talk to your friends? You giving more guidance to your medical professionals and your powers of attorney, your agent, so they know, so they can, if you guys are like, no, this is what they wanted, the burden's off of you, look here, then they go, oh, that is what they want.
They're not walking into a shitstorm either, being like, well, wait, what? And you're just like, no, that's what's listed here. And they had no idea, or they're just like, oh, shit.
So what is that? What is the actual, so go back to the pulse. So this is also what a lot of my older clients will have. I'll come to their homes and I'll be doing this and I'll see the pink on the fridge, and that's for the first responders as well. So once you're in the hospital, they'll put that above them, the pink form, or if you're still in your home, they'll have it on the fridge, because that's where the first responders are immediately going to look to see what you want done when they show up to your scene. If you've had a heart attack, you have a stroke, or whatever it is, you fall down, whatever. So they immediately look at that. So it's a very important document to have. It also supplements your estate plan. So this is like immediate things happening as opposed to like, okay, now you're in the hospital for a long time. What's going on with this situation? How important are these things to you?
Yeah.
So
the hard part is that we see sometimes is that this is not necessarily set in stone. This can be changed.
Right.
So if in the moment, and that's probably the hardest piece that we see, is that in the moment, we see patients that are short of breath, or they're kind of realizing that impending doom is starting to come upon them, and they said, I may have this pulse already form filled out. In the moment, like I want you, I want you to do all the things. So if the patient is mentally capable of making a rational decision, they are capable of changing their care plan at any time.
Right.
And one of the things that they're harping on us, especially in nurse practitioner school currently, is that you have to do patient-centered care. And so it's the patient's making their decisions. We're not making their decisions for them. You're not making their decisions for them. They are the ones that are making their decisions. And so, but again, with that piece is that we come in with a plan, and then in the moment it changes. You're like,
I was going to lunch at noon. I guess I'm not.
You're like, you just ruined my day. Get the paperwork out. And so sometimes it can be a little bit of an issue, or you have family members that sometimes will talk the patient into making changes.
I've seen that.
And in the moment we have one set of plans, and now we're doing something completely different because this is what this other person wants. And so they can change it at any time. You can have it rewritten every time. This goes with the patient. If they leave me, if they're well enough to leave me and go home, like you mentioned, this will follow them. If they go to a nursing home or another facility, it will go with them. It is helpful because it does help the physicians and the nursing staff determine to what degree we need to be aggressive with this patient's care. Is their focus primarily on their symptoms of pain? Do we want to just treat whatever we need to treat, but pain is the biggest issue, so let's take care of that? I mean, you literally, and I'm sure like you said in your paperwork, you can specify to the nth degree exactly what you want your plan to look like. Like, I don't want Dilaudid, I want specifically morphine to be given to me every, within what the doctors can do. Typically it's like 2 to 5 minutes you can give pushes all the way through. So, but yeah, it is very handy to have.
Yeah, and it's important. And I always, sometimes we have clients that I'm working with and we have family members hovering. And sometimes I'm like, please just go out of the room for a minute, and you have to talk to them and be like, is this really what you want? Are you doing somebody else's wishes? And that's why it's important to put somebody, and I have a lot of clients who are like, oh, I'm putting so-and-so on there because they will smother me with the pillow, or they'll do what I want. They'll advocate for me strongly, as opposed it might not be the same people you have managing your assets or managing your trust or managing your powers of attorney for finances. A lot of times it's opposite. They're like, oh, this person's really good with finances, but they're very emotional. They'll not honor my wishes because they want me here. And of course we want our people here, you know what I mean?
But some people have different reasons for why they want you here.
For sure, yeah. And also with our powers of attorney, we can have them religious-based and centered. We have a Catholic one, there's certain beliefs and things that we can go in there about what they want. Jehovah's Witnesses have a different one because of the blood issue. There's a lot of things that we can really tailor for your life, your beliefs, your whatever your well-being that you want. And so the medical professionals love that, so they can honor your wishes and follow that. With that, so you've discussed like what this looks like. So what is the actual process of dying look like? So I know there's like certain key indicators. Maybe they change a certain color, the way they start acting, the way they start sleeping. Like, what's that look like?
I mean, vital signs are huge, right? So blood pressure is one of the biggest ones that we look at, and we can administer medications that we call pressors, and those are going to keep your blood pressure up. Typically, if you have a patient that's on at least 2 or more, we can go up to 4 or 5. If you're typically on 2, things aren't looking great, right? That we need that extra little bit. And other certain things, how their mentation is huge. Are they not with it because they're on medications to keep them sedated? And typically most of our vented patients are on some sort of sedation, right? We're not monsters. We want to keep you comfortable. We put you in la la land. You typically don't really know what's going on, which we can turn off, and often your body can metabolize that. You wake up within minutes, right? But if you're not waking up, if you're when you're not on medications and you're still not mentally capable of being awake or responding, following commands, if I say, Lindsay, squeeze my fingers and you do nothing, I pinch your toes and there's no pain response. We can do other things like checking for electrical activity in your brain. That can show us a lot of different things. So if you're not mentally there, as well as having signs through your vitals that are showing that your heart is overcompensating for itself, you're like I have you on a ventilator because you can't breathe on your own. Your blood pressure is in the tank and I have you on multiple medications just to keep you alive. And then overall what the chronic condition and prognosis looks like. So, we start to see patients that are breathing, what we call agonal breathing or chain stoking type. You can only do that for so long. You run into metabolic, or I should say respiratory acidosis, right? Where you have too much carbon dioxide in, and that's not great for your brain. And then if you're tachycardic, if you're in your 20s, you might be tachycardic for a long time. But if you're in your 80s, your heart can only beat at 160 beats per minute until it finally just can't anymore. So it is patient specific, but for the most part, the criteria are your vital signs stable or not? Are we giving you medications to maintain that stability or not? Are you able to breathe on your own, and to what degree? How much oxygen do you require to maintain a certain quantity of oxygen in your blood to supply perfusion to all of your vital organs? And then overall, like, what are you in here for, and what have we done to try and fix it? And if we've exhausted all of our resources, ultimately those are kind of the things that the doctors look for to say, we gotta do something.
Yeah.
Right. We need to have a conversation with the family, because sometimes, like you mentioned, it may be religious, it may be cultural, that they say, oh, this person was in a massive car accident and they need blood, but they're a Jehovah's Witness.
Right.
What do we do?
Yeah.
Having that conversation with the family members or whoever you're appointed, either your surrogate or your power of attorney, would say no.
Or having those faith-based people come in, advocating, with the family.
And, and that's always a tough one too. Religion is always a difficult one to kind of, again, we always want to try and accommodate as best we can and be respectful of people's wishes. But, and then when that's the case, because healthcare to everybody looks different, right? Or like, what are your priorities? I've had patients that have been super sick and they don't give two shits. They want to get home to Fluffy because that's more important to them. And I'm like, so you want to go home? I mean, I would too. I was like, bring Fluffy here. Like, I won't look. Just making sure that, again, it's a conversation, and I don't think that enough people talk about it, whether it's within your family or with your lawyer, or if you have a friend that's a healthcare provider, ask these questions, because it can be super helpful. I had a friend who just had her brother-in-law pass from cancer, and the idea of comfort care was on the table. She had no idea what that looked like. So she called and she asked, she's like, what can we do to help this? Like, what does this look like? Does this mean he's going to die tomorrow? I was like, it kind of means whatever you guys want it to mean. If he's not well enough to maintain a length of life, and they say he only has a couple days to live, you can run through those days, or you can just say, let's spend our time with him and not make him suffer anymore, and we can speed this up a little bit by giving him medications. And so, but yeah, just reaching out and asking people, or again, don't listen to everything you read on the internet.
Google University, everyone. Don't do it.
Yes.
Listen to your professionals.
Yeah, the number of times that someone tells me, oh, I know what's going on with me, I Googled it. I'm like, Jesus Christ.
WebMD, you're just going to die regardless. You stub your toe. That's how it. Yeah.
And you have cancer everywhere.
Everywhere.
Yeah. Comfort care can be what you want it to be, which is very nice, but it's all about a conversation with you as the patient, you as the person that's filling out your power of attorney, and then with your healthcare staff, just being open about what you want.
So when someone passes, a lot of things happen to the body that a lot of people don't understand or realize. Let's talk about the fun things of dying.
The fun things are dying. Everybody shits.
Yeah. Yeah, your bowels release. I don't think people understand that.
I would say probably the hardest part, like I mentioned before, when we do the post-mortem care and then families come back after we've kind of cleaned the patient up. A lot of times eyes stay open, mouths are agape, It's not pretty.
Well, that's gravity. I mean, that's natural. Like you're not holding everything together because you're super relaxed.
Your skin turns sallow. You get like, it's almost like a grayish yellow. It starts to get like this thickened appearance. And it's not a fun thing, but
nor does it smell well.
No, definitely does not smell well. And that's another piece of what we take care of, is that if that should happen, we kind of put things in places to help catch some of that, and it's always a thing. I will say, when I was first learning about what death looks like and doing postmortem care, no one told me that when you turn a patient over, they still hold a certain amount of oxygen in their lungs. I went and turned a patient, and that it didn't happen when I pushed the patient away. It happened when I pulled the patient towards me, and air escaped from their lungs, and it sounded like this horrific death rattle of and I thought the patient was still alive and almost shit my pants. Like there's, oh
my God, that's looking wrong.
Yes. And so, stuff like that happens.
Zombies.
Yes. Yeah. Sometimes you get, even though we can tell that patients have died, we've had them hooked up to the monitor still, and it will still show what we call pulseless electrical activity.
They're still floating around in there a little bit.
Yeah. So, but family members look at that and they're like, shit, like Mama's still alive. And we're like, she's very much dead. But, stuff like that. If we remove IVs and things like that, you still bleed a little bit. Gastric juices can come out. So it's not a pretty thing. So we try and, again, do our best to put things to avoid that, so that family members aren't concerned
privy that.
Because
I mean, a lot of people don't know that, and that's why I think it's interesting to talk about, because you just think it's like in the movies, and you just, and you shut your eyes and you just pass away, and it's so nice. And it's like, that's not, as in life is messy, so is in death. You know what I mean? It's like, you think about it, you are a meat pocket. There are a lot of fluids within us.
Yes.
What are we, 70% water or something, or fluids, you know? We have a lot of blood within us. And so when you're no longer holding those things together with your muscles and your sphincters, like that's all relaxed. All that stuff's got to go somewhere, because you're not holding it in your meat pocket anymore,
Right. So. And depending on if it's a traumatizing code, if you're trying to code somebody and there's blood everywhere, it's not a pretty scene, and it's a lot of work that goes into trying to save somebody's life in the midst of a code. Communication is huge. Designated roles and things like that. I've seen codes go great, and I've seen codes as complete shit shows where nobody was communicating. You've got multiple people speaking over each other. And again, as a family member, witnessing all of that and physically seeing what we have to do when we put hands on patients and putting IVs in and, poking them with needles and all of the things, labs in there, it's not a pretty sight. And I've had patients where they didn't have anything set up. They start coding. Families, we've been trying to talk to families that, like, you guys need to make a decision. And it's a tough decision, 100%. I'm not ready for it when it happens with my family members by any means, and I'm
even though we deal with it every day. It's awful. Yeah, it's awful.
It's different when it's yours, obviously. And so, but we've had cases where it has come to the patient literally coding for family to understand that this patient is dying. Yeah. And and I don't know if it's just.
It such a taboo of death.
Well, or like an emotional response that you just shut down and you're not processing what I'm trying to tell you. One thing that I absolutely hate is that I can, to a degree, have conversations with families and patients and their family members about what's happening. Again, nurses are at the bedside 23 hours out of the 24-hour day. Docs are in and out. We know what's happening with these patients. And you get those patients that are like, I want to hear it from a doctor. And I'm like, fuck you very much, because I'm almost one of them. Right. Yeah. So, it's difficult, but legally
like you said,
I have to.
But you are in the trenches, you're in the day-to-day. You're actually talking to these people where, like I said, a doctor, obviously they went to medical school, but oftentimes I have found that they don't really know, because they're not in their day-to-day.
Yeah, and they trust, like you had asked, you're like, what do you start to see the patients get into before you're like, shit, this person's getting close to dying? And so we are the ones at the bedside doing all that. Doctors trust, most of them, trust us to make those clinical judgment calls of like, this patient's not looking good and I need to act now. So when we have these moments where these family members are not processing that, and it literally comes down to the point where we are kicking them out of the way because this patient, either their heart is ready to burst, or to just stop altogether, that it takes that physical action of me beating on your chest and screaming. I mean, it usually is. There's not a code where people are like, oh, Lindsay, could you please get me 1 milligram of epi?
Right. Yeah.
I mean, it's like, it's a high, intense, emotional, like, give me this, give me that. And so, families seeing that and seeing what you physically have to do to a patient in order to, start CPR and put NG tubes in them, physically like tube them to put them on a ventilator so that they can breathe. It's not a pretty picture by any means. And then you get these family members that are distraught because they're watching all of this.
Right.
Again,
awful.
I'm not a lovey-dovey type of person, so it's never been my job to confront or to keep comfortable the family that's at the bedside. Thank God that I have other nurses that I work with that are, the little Care Bears, that they're just like, it's okay, come right over here with me. And they sit with the families and they try and keep them calm. If they're witnessing that, half the time they just take them out of the room. And then we bring them back in when we've either stabilized or not.
Yeah.
And then have them decide, like, I can't watch this anymore. I can't have this be the way that they go. And so then they'll make that decision to pull the plug, basically, and withdraw care. So, which is sad. It's like, again, I would not wish that on anyone, to either be the person that's happening to or the family member that's watching it. And so having these sort of plans can avoid all of those situations and keep things a little bit less traumatic for families as they're witnessing the death of a loved one.
Yeah. Yeah, you want that to be like the movies where they're like, okay, and we just let it go, and we're peaceful, and we're kumbaya, and it's wonderful.
It's very notebooky.
Yeah, but that's not how life works.
Nope.
So always have a plan in place.
Yes.
Awesome. Well, let's do our wine talk today. So you also like wine. Molly also likes wine. So today we have one of her wineries that she likes. This is Tanner. It is a reserve Cabernet Sauvignon. 2017 from the Sierra Foothills. This is on the different side. This is Murphy's. So tell me about Murphy's because your family is from this area.
Yes. So both of our folks are from, my dad grew up in San Andreas, California, which is just about a 30-minute drive from here. And my mother grew up in Arnold, which is about a 15-minute drive from Murphy's. And so they're high school sweethearts. It's amazing that they've kept things going all these years. They just celebrated their 50th wedding anniversary. I know. We're like, it's okay if you guys wanted a divorce. We wouldn't have been mad about it. But they
still really like each other.
They're old school. They're like, we can work on this. We can fix it. And anyway, so they grew up in that area. And then oddly enough, my husband has roots with his family in the same area. And so that was kind of weird. We had to definitely make sure that we weren't cousins before we started dating. Yeah. But this particular winery, my parents went to high school with the kids that now, well, I shouldn't say kids, they were kids at the time, with the people who own it now.
Yeah, which is fun.
And so that's kind of fun. And that's not the only reason that we like it. It's actually
great
delicious wine. And they do, my favorite is the Day of the Dead Red. It's a blend, I believe. But so Calaveras.
We brought that out, but we have drank that long ago.
Calaveras County, for anyone who speaks Spanish, is, Calaveras and all of that. They're very much into skeletons and bones and things. And so they do a play on Day of the Dead, and they make the Day of the Dead red, and it is delicious. In fact, that's what we drank for Mom and Dad's anniversary, because it was fun. Dad's birthday, Halloween. Their anniversary is on November 2nd, which is part of the Day of the Dead. And so we did like a whole collaboration and drank their wine.
That's fun. Yeah, you guys have Hispanic roots. Your dad family is Hispanic, and which is interesting. Your mother is very Irish, and so it's a good melding.
We look like this.
Yeah. Yeah.
Not as vampiresque as that over there, but yes.
You can't be more Irish than this. Yes. But yeah. So yeah, it's kind of fun that you guys have those roots and that family lineage, which is really cool.
Yeah, it's a beautiful area. It's just on the other side of the foothills of California and Highway 4. My grandfather was Forest Service in the area and ski patrol up at, I think it's Bear Valley. And it's a beautiful little resort up there. So yeah.
That's super fun.
Yeah, we love going over. In fact, I was supposed to go last week, but we didn't make it.
We did not make it. Yeah. No. Again, if any of these wineries would love to sponsor this show, I will take your wine all day long.
All day long. Yes, we will drink it all the time.
We'll drink it all day long. So yes, thank you to the winery there, Tanner.
Yes, cheers.
So you working in the medical field for so many years, what is your most fun or favorite stories? We used to tell these at soccer practice, so this is why I would like to hear some of these for you guys, because they are quite entertaining and riveting.
Oh, goodness. Well, I have to do the one that I was working at night. So
you're in for a treat, everyone.
Yes. So I was working night shift on the med-surg floor, and I had a patient that had come in that had a bowel obstruction, and with that comes, you're not go into the bathroom and, you get abdominal distension, nausea, vomiting, and all the things. And the surgeon had gone in and reversed this bowel obstruction. And we typically give patients like 2 to 3 days to have those bowels naturally come back into working. So a lot of medicines and just kind of trauma can shut down the peristalsis of your bowel, right? Food moving from one end to the next, creating stool.
Just makes you really
out.
Constipated.
Yes, yeah. So you
a lot
basically
of those opioids do that.
Yeah. And what we do from nursing side is we're looking to listen to bowel sounds. Are you passing gas? That sort of thing. Well, I was on a very good health kick at the time, and I was eating nothing but like raw vegetables, and
a lot of kale, a lot of broccoli.
Yeah. And we had a very attractive gentleman that was working the night shift as one of our doctors doing his rounds. And as I was coming around the hallway or down the hallway, I see him start heading towards the room, and I'm like, oh my gosh. I was like, okay. And he tells me, he's like, I want to go and check in on this patient. And I'm like, okay. I could not control my back end and let one out, silent but deadly, to the point where the physician was so pleased with this patient because he's like, yeah. He's like, you're definitely passing gas. This is great.
Yeah,
like,
good job. We can get you out soon.
Yeah, things are working. We can increase your diet. We can do all these things. And I knew damn well that patient was not ready to be advanced. So I had to come clean and basically tell this doctor I just shit my pants. And that the smell that he was smelling was not the patient, did not mean that his bowels were working well, and it was me. But that's not the only time I've had that situation happen.
Again, bodily fluids and functions.
It always leads to it. My poor mother. I was working one night as well, and I was getting a report on a stroke patient. And when I went in with the nurse to do bedside nursing report, I'm talking to the patient. Hi, I'm Molly. I'm going to be your nurse today. And he just looked at me, didn't say a word, just looked at me. And she had said, this guy had a stroke and he's been nonverbal. And I was like, okay, I had a stroke I think less than 24 hours prior. So I'm like, okay, I said, I'm going to get a report on the rest of my patients. I'll come back around and look at you. And again, it was nighttime and I was still on this little health kick. And so walked into his room after seeing another doctor. And I was like, oh, I kind of wanted to avoid that doctor. So I pop into this guy's room. It's pitch dark. It's 2 a.m. I thought the guy was sleeping. I rip one. And it wasn't a silent but deadly, but it was loud and very not...
loud and proud.
Yeah, very foul smelling. And out of the darkness comes this voice of this man saying, if you've come in here to check to see if I've shit my pants, you might want to check your own. And then the light turns on, and this man that I thought was completely nonverbal is sitting there staring at me, completely dumbfounded that I just came in and basically shit my pants in his room. And he was just like, I can't believe you just did that. And I'm like, you can talk. Like, I thought I cured this guy. Yeah. I was like, motherfucker, I knew you could talk. And he was just like, I just didn't want to. And I was
your flatulent has cured the ill and the infirm. You should be like a saint.
I should.
A saint of flatulence. I don't really know. Yeah. You cured the infirm.
It's been a very interesting ride. I mean, I could tell you stories day in and day out, and my husband does not like to get together when I'm with other nurses because it's just
more stories,
all the stories. But I will say one in somewhat relation to why I'm here today is, and it was a beautiful, and you know me, I don't cry, people joke I don't have a soul, that sort of thing.
Like, that's why we're friends.
I have chest pain and I don't know why. Yeah. We were taking care of this woman who had MS and for multiple sclerosis, and it's a disease that affects the nerves, right? And it's kind of like cancer. There's not really a whole lot of things that bring it on. It just kind of happens. And so she had been coming in and out for treatment for like the last 3 to 4 years. And she very much had a plan. Her husband was listed as her power of attorney, but they said, we want to try all these things. And if you're telling me that nothing's going to work, then let me go. And so off and on for 3 to 4 years. In that amount of time, you kind of get to know somebody, right? You get rapport. And again, we're in these patients' rooms 23 hours out of the day. And so they get to know us whether they like it or not. And so, but she was kind of a one-of-a-kind lady that just went with it. You get a lot of people that they have these diseases and they treat them as if they're curses, right? And it's damn be all. This woman was just like, let's try this. Let's see what happens. I've never seen a more positive person take on their condition, but this woman. And So unfortunately, her last trip this last week was, in fact, her last trip. And we tried to do some type of treatment that is almost kind of, it's like plasma mixed with another sort of medication that basically just kind of keeps the breaking down of the nerves and the pain and all the other things at bay. Well, her MS had gotten to the point where it was starting to affect the nerves of her lungs. So it was basically everything from like nipple line up was what she was really being affected by. And it was starting to affect her ability to breathe. So we ended up having to put her on a ventilator, and they wanted to try a bunch of other medications. And she was with it. She was not sedated. She was awake on a vent, which is a very rare thing. Oh. And, able to, and I can tell you I'm really good at charades now, because she would point to things and do little, charade type things to try and communicate with stuff. Or she'd have like a whiteboard that she'd be able to talk to us through. But most often she's always like doing this. She was doing like sunset heart hands. I was like, oh my gosh, we'd do like half-seas with her and things like that. Super sweet lady. And the last round of medication didn't work. And we tried to take her off the ventilator, and she said, I don't want to be re-intubated. I don't want to live in this hospital bed. This is terrible. And if this means, and granted, she was in her 80s, but she had lived with MS for years, and it's a quite debilitating disease. And she said, nope. She's like, this isn't what I want to do. And she said, call my husband. So we called her husband, and he came in with his 2 daughters, and they sat there, and we pulled her off of the ventilator, and she had about an hour's worth of time to literally pull each one of us in. Like she said, she'd say, like, go get Molly. And I'd come in, and she would say things like, in particular, she knew I was going to nurse practitioner school, and she said, I wish you nothing but the best. And I was like, We have another gal who's getting married, and she would say things. You're going to make me cry. But we watched her go, followed her wishes, and it was beautiful. And it was one of those moments where it's like, you can't ask for anything better, and that's why this stuff is so important, because it allows us to really focus on the patient and give her what she wants. So she left us, but she was awesome. We all went out for drinks afterwards and did shots for her. We asked her as she was leaving, because we told her, we're like, well, and she said, she's like, don't cry. She's like, everything's okay. I'm not scared, that sort of thing. So it was beautiful in that piece. And we asked her, we said, we're going out for drinks. What do you want us to drink and toast to you? And she said, tequila. We're like, perfect.
Yeah.
Perfect.
Thanks for the drink of choice.
Yes. There. And so there was a little Mexican restaurant right down the street, and we went and did drinks, and our boss paid for it all. Thank you. Thanks. Our boss paid for it all, which I thought was
Look, we
fabulous.
have souls, everyone.
I know.
Man.
Feelings. Don't tell people. They'll have expectations.
Right.
But anyways, it's moments like that obviously remind us why we do our job, why we ask that things like this get taken care of, so that we can do the best by the patient and not have to deal with drama in the midst of someone passing. We want nothing but death to be peaceful. Right. And having some sort of plan, getting your ducks in a row. It doesn't take time. I've done it myself. Yeah. It doesn't take time to do, and it just makes life easier for yourself, for your spouse, for your significant other, your family, and for us to make the right decisions to allow you to have, again, dignity and the choices that you want before you die.
Very cool. And on that note, thank you so much. Look, we have souls. And of course, when you think of death, think of me.
Yes. And I don't want to see you. I don't want to see you in my job, but take care of yourselves.
Yeah. Yeah. But if you have to, they're there for you, and that's why our medical professionals are there. So kudos to you. Thank you, friend.
Thank you. Cheers. Thank you for the wine.
Yay.
Cheers. Cheers.
Thank you for listening to this podcast. If you found value, please like, subscribe, and share. And be sure to follow me on all the socials at Sips and Tips with Lindsay. And of course, you can always go to my website, sipsandtipswithlindsay.com, to find more information about estate planning, business, snowboard, travel, and of course, wine. As always, we have to get the legal stuff out of the way. I went to law school, so you don't have to. However, we have to read the special disclaimer that I am not a practicing attorney. I am not your attorney. I am not offering any legal advice in any content or any episode. All content is for your information and educational purposes only. It is not a substitute for seeking your own legal advice from your own attorney or other professionals such as a CPA or financial advisor. I cannot give legal advice and do not offer any legal services or legal advice, but I do offer some fun and educational content for you to enjoy.